Good afternoon, everybody. Welcome to Digital Health on Air. My name is Aditya Bansal. I'm one of the founders and CTO at Luma Health. Today, I'm joined by Brighton Ncube, who is who used to be, I should say, the SVP of Ambulatory Care and Physician Practices at Kingman Regional Medical Center. Welcome to Digital Health on Air.
Thank you. Thank you.
Very excited to have you here. So I'd love to start, these Digital Health on Air episodes with just a little bit about your background, kind of what brought you into healthcare. Would love to just get a little bit of our audience comfortable and familiar with, who you are and, what got you into this profession.
Yeah, no, my name is Brighton Ncube. As you said, I've been in healthcare for the last 26 years. So I started healthcare from Africa. So those were the years in the 90s when HIV/AIDS was in Africa. So I really, first I taught in high school, then I didn't quite like it. So I joined a non-profit where, I was involved in the interventions for HIV and AIDS. So those were the first years. There were no ARVs. Absolutely, there was nothing. It was just positive thinking, good nutrition. That was the treatment.
Sure.
We started really going into communities, also meeting people who were living with HIV, trying to provide support. Then after that, I then moved to Leonard Cheshire International. So this was a non-profit that really dealt with people with physical disabilities. So I covered 10 countries in Southern Africa. So really the goal was, for them to be self-reliant.
Sure.
To really get employment, get technical skills in terms of training, and also for them to really survive on their own, and also really to make sure that the host governments can accommodate them in terms of, like ADA compliance, all those things. Yeah, then from there, I came to the United States, where really most of my work focused on healthcare, ambulatory to be specific.
Yeah, amazing. And, I know that you have a really strong sense of purpose around population health in communities, is that comes from your time maybe working with, the HIV/AIDS population, or was it something that else gave you kind of that inspiration to work in pop health?
Yeah, I know it comes obviously from the background. So
sure.
I really always believe that as healthcare providers, we just have to provide the best care possible to our patient population, and also to really find ways to manage their health in a more effective way. So really, that's basically the background. For example, we have a lot of, mechanisms to really manage the health of the population. We can do a lot of screenings, whether it's depression screenings, cancer screenings, etc., which is really a good way of closing the care gaps.
Yes.
Different populations. But then if we don't do that, then which means we are not really providing good quality care, because we are not really, managing effectively the health of the population. What then that translates to is that some of the cancers we catch, they may be being stage 4.
Very
difficult to treat. So I've always been passionate about how do we really become proactive in what we do, and how do we make sure that our populations are well managed, and what are the resources that are available to us that we really need to use. At the same time, the flip side really is that we need to educate our population, because they need to also to be in charge of their health.
Yeah, they have to be invested in their own health outcomes.
Yes, definitely. So there is that element of outreach, that element of education, that, this is critically important, that you get your pap smears, you get your colorectal cancer screening.
Yeah, you get your breast, your mammographies, that sort of stuff. Totally. So, that's a really interesting thing, because in when you have a clinical set of things you're trying to achieve for your patients, the other side of it, which is challenging for a lot of ambulatory leaders, is access. Making sure you can provide the slots, into the communication to the community. How do you kind of think about, as an ambulatory leader, combining or kind of leveraging, I should say, the work you're doing for, identifying care gaps, getting in front of them, but also trying to manage access as well?
Yeah, I know what I always do really is to understand my population, what's the demographics of my population. So that way, what are the barriers to care for those different types of population. For example, I've worked in rural communities.
Sure.
Where I had a lot of retirees. obviously most of the barriers to, access becomes transportation.
Yes. Yeah. I was going to guess you would say that, but it makes sense.
How do we then plan around that barrier and also make sure that they can access healthcare? Then the other, in terms of access, really is to think through in terms of saying, what are some of the platforms that can be used? You find that healthcare, maybe I'll give this analogy, like when you have an aircraft,
sure,
it means that different industries have contributed to that aircraft. Some producing the tires, some producing
making the wings, but it's not one company, right?
It's not one company. So that really is the same concept in healthcare, that we cannot do it all. We need supporting organizations for us to be successful. Some, they provide technologies that we're supposed to use. For example, I think Luma Health has expertise in access, patient
communication, access, exactly.
All those things. Yeah. Also, maybe you have some technologies where patients can even do their co-pays, payments from home, and they can do their registrations from home. So that really explains to the fact that we are not an island as healthcare providers. We have to really incorporate a lot of industries for us to be successful. Still on the concept of access, it means therefore that like telehealth, we saw telehealth being effectively used during COVID, that it was no longer face-to-face because we wanted to really manage the pandemic.
Provide service at home too, right?
Yeah. So then we implemented a lot of telehealth platforms, and those were really successful. And up to now, they are really successful. For example, at Kingman, we had a backlog for cardiology. So then we signed a contract with a provider for telehealth services where our patients can see cardiologists via telehealth who are in other states.
Oh, interesting. So almost like a virtual clinic kind of model.
Yeah, virtual type of a clinic. So those are some of the strategies to really increase access and also make sure that you are...
That's a really great idea, to add capacity without necessarily building a building, creating an exam room, whatever.
Yes.
Definitely. Some of these like pop health strategies, I know you at Kingman had like spearheaded a hepatitis C kind of intervention program, and it was quite successful, both in terms of like identifying the population, but also making it so that like people who had affordability issues were not necessarily prevented from service. I'd love to kind of hear just like that specific example, a little bit more for audience about how you made that come to life, because I think you covered a whole lot of ground. I remember it being a very, very cool, specific thing you guys accomplished at Kingman.
Yeah, so really it boiled down to really coming up with a plan, because like when you want to execute a successful program, you just have to have the right players. You just have to really develop a process to say, this is how we are going to implement this program. You find that oftentimes people are not successful, not because they're bad workers, but because they haven't developed a good process to accomplish what they're thinking of accomplishing. So what we did in Kingman really was really have obviously a registry to say how many patients we want to reach and what are the outreach strategies to reach those patients, and how do we really communicate the benefit to those patients, and also how do we really create an avenue where those patients can access our services. For example, it won't be prudent for you to outreach to patients only to find out that you can't see them because...
when you have no service capacity, right?
Yeah. So it was really something that we did deliberately to say there has to be access, there has to be a process, and there has to be an effective outreach to reach all these patients. So then those are the success factors.
Did you combine, so there's like you probably identified this population, this registry who had gaps in Hep C screening, but you also probably were seeing some of these patients in the clinic too, right? Just with the routine care. Was there like an in-person and a digital strategy, or like a gap in care strategy? I'm curious what the in-person side looked like.
Yeah, it was a combination, in-person and also a digital strategy. For example, in your EMR, you can set some reminders.
Sure.
Say, like when patients come to the clinic, these are things which we will check. That way you are, closing care gaps. That's what we describe as a quality visit. So when you want to be successful, you just have to have those guidelines to say, if someone comes to my clinic, what is it that I'm going to describe as a quality visit? So a quality visit will compose of these elements that...
Yeah, the patient's prescribed problems plus any care gaps that I might have identified and maybe some other stuff as well.
Yeah, yeah, yeah.
I love it. And then, so that was, identifying the population, digital plus in-person strategies with that quality visit concept. And then, I imagine there's, for a lot of these patients, like one and done isn't enough, right? Like you have to communicate them a couple times. Like you said, give them education on why this is important. Like, how did you fill in those gaps as well?
Obviously, we educate them. They have patient portals where we send the information for them to read, as part of the education process. Then also in person, when they come in person, you educate them in terms of saying, okay.
Yeah, in person is probably the easiest, right? Because you have a physician or a nurse, a trusted voice. Yeah.
Yes. Then the other thing you mentioned before I forget was really that element. You can set up like an appointment, but then they have to be reminded so that they don't miss the appointment. So that's where, a lot of, companies who are experienced in that field come into play to say, how do you help us to have effective patient reminders so that people don't miss their appointments? Because, a lot is happening in this world. People get, busy and they forget.
Oh, yeah.
But then if you...
It's family obligation, work, it happens. I mean, even the best, even the best patients have their own lives, which are, they're also people too. They're not only patients, right?
Yes, that's true. That's true.
So, that's, you talked a little bit about strategies for getting those, patients in, making sure you educate them, in this context, the Hep C example. But I imagine like in your expertise as, running ambulatory teams, there's many times you've had to work to get patients back in for care, not just the routine kind of sick visits, but also other sorts of like, getting patients in for back care. What are the strategies you've used to get patients in for return for the necessary care?
Yeah, it depends on whether is it a scheduled appointment. For example, someone comes and says, "Oh, I'll see you again in 3 months or in a month's time," but then someone can suddenly get sick, and want to see a provider. So we established a virtual same-day visits where someone is guaranteed that when they want to see a provider, they will see someone. So we have been utilizing those virtual.
So if I'm the patient, like how long am I waiting for that virtual same day? Is it like minutes, hours, or just like the guarantees I'll get you today?
Today.
Okay.
Yeah. It's guaranteed in less than an hour. If they just log on to their portal, then they are connected, or they call the clinic to say, I want to, schedule with the same-day virtual visit. Then
I'm sure a lot of our folks or a lot of our attendees would be really interested to know, how did you staff that team? Like where did you find the resources for that same-day team?
Yeah, we just created like a model which we thought was going to work. Like, you have the technology, then you have a medical assistant who will then help the patient to navigate the whole process. Then obviously have a provider who will be waiting for that patient to connect. Then they just connect virtually that way. Then the provider will then prescribe for the patient to go and get the medication in the pharmacies. So that's how easy it was really to set up. Obviously, the charting and everything is done by the provider. Then also as the medical assistant is helping the patient to navigate, then that's when we do the registration, because you have that patient registered for that particular visit and everything.
And then you're off to the races, right? Like then it's like you're in the care delivery itself.
Yeah.
So let's kind of change directions a little bit, like less on specifically where you are in the world of, the things that you've done most recently, but kind of would like to get your opinion on a couple of things. So there's a lot of hospital M&A. A lot of hospitals have built out ambulatory capacity to be able to service their patients better. What do you think? What do you think is important to help keep these health systems, these independent health systems, as independent? Do you think ambulatory care plays a big part of it? Do you think there's no hope? We should all become parts of HCA? Where's your head at, and what do you think they should be doing?
No, I think ambulatory plays a key part, because as you expand your footprint for ambulatory care, then that's where the hospital then gets referrals, whether for for procedures, for surgeries, etc. Because now you have a good footprint of ambulatory care, then the primary care providers are able to refer to the hospital, and also that way you really effectively manage the population. And on top of that, you reduce the costs for the hospital, because you are seeing a lot of people in primary care, they don't end up in the emergency room. Because you have...
I mean, this goes back to the population health screening, like your pollen, your mammographies. It's like, I'd rather see you stage 1. I don't want to see you stage 4, right? I'd like to catch it sooner so I can help. And more effective treatment, it's better for, morbidity and mortality, but it's also better for like system cost as well.
Yes, definitely.
Yeah. What do you think are some of the bigger innovations that you've seen in ambulatory care in the last 5 years? Take out COVID and virtual, because I think that's kind of, you guys did a great job at that. But what are some of the bigger innovations you've seen?
Yeah, there's been a lot of innovations in terms of really implementing some of the methodologies which were prevalent in manufacturing industries, like really bringing those lean processes. Or lean,
like Kaizen style.
Yeah, Kaizen stuff.
Yeah.
So interesting. How that is worked is like, for example, when clinic managers are managing their clinics, when they apply those principles, for example, they will have a huddle board, which really outlines what are the metrics which they are tracking for their clinics. It outlines which care teams are present for that particular day. Then also, the huddle board also has an improvement center where the clinic or the hospital can really focus on specific improvements. You'll find that in healthcare, constantly we have to improve things.
Yes.
So you just have to have those A3s, which are from the manufacturing, but now applying them in healthcare to say, okay, this is how we really do process improvement. This is how we monitor our operations. And this is really how we celebrate our successes, achievements, as we do all of these things. Then the other really thing that is really in the last 5 years, we have placed emphasis on patient experience.
Sure. Okay. Yeah.
We want oftentimes to make sure that when patients come to our facilities, they have the best experience. So in that regard, we really make sure that the waiting room is welcoming. We structure the healthcare system in a trauma-informed way. We don't have those images that will traumatize patients. We really make it clean, welcoming, and also the people who are registering, welcoming the patients. We script. How do you make someone?
Yeah, you're very deliberate in the experience.
Yeah. Then after, the patient has gone right round the cycle, then before they leave, we ask them, is there anything else I could have done for you?
Oh, interesting. So you're asking for feedback and process improvement at discharge or at field, I guess. Yeah.
Yeah, because if the patient feels, oh, but you didn't check my ear or you didn't do this, then you can say, okay, let's go and do it. You see, that
we could do it now, right? I can help you right now. Yeah.
Then in that respect, the patient then leaves with a good experience that, oh, they did everything they could do. And they even asked me if I needed more done, So that way you are putting the patient in the center, and also you are showing how much you appreciate them and how much you really can go, above and beyond to help them to treat their conditions.
Yeah, I love that. I mean, I think that little tidbit of asking the patient at the end, is there anything else you need, or what could I have done better, or whatever it is, the real-time feedback loop becomes really important for this. Going back to your saying, lean or Kaizen style manufacturing approaches, constant interaction, constant data feedback.
Mm-hmm. Yeah. So then also I wanted to say, also we monitor, we make, in fact, data-driven decisions when you apply healthcare. So that helps us really in terms of saying, okay, for each particular service line, what is the wait time? The third to next available appointment. So if we see patients are having to wait maybe 4 months or 6 months to see, let's say, as an example, a cardiologist or to see a neurologist, then we question, why is that? So then we go now into a process of saying, how do we implement different interventions to reduce that wait time? For example, in one of the systems that I worked for in Northern California, we had a wait time of 9 months for colonoscopies.
Sure.
So then we developed a team who were going to implement a process improvement to say, how do we reduce, that backlog of colonoscopies? So
Yeah,
it
one
was
of the
a
crazy things about those like really long backlogs, if I've been waiting 9 months, I may have gotten service elsewhere, but the person who's 10 months behind, like they actually may need the service, and you don't know until you actually start actually going through the backlog. I share this problem time and time again, which is long backlogs require incredible amount of like attention for process of improvement.
Yes. Yeah, so with those scopes, so we had a multidisciplinary team we formed, then they developed processes, then they developed standard work that was going to guide the whole process of improvement. Then obviously you adjust and improve as you implement the whole process. So we reduced from 8 months wait time. In fact, it was 9 months by the time we finished the, planning the improvement. Then we reduced to 3 weeks.
Wow.
Yeah. So we even were doing scopes over the weekend just to address the backlog. Then we also had some part-time GI docs who were coming to help us address the backlog. But once we were caught up, then we made the point that we're not going to...
We're doing like our 9 to 5, Monday through Thursday. Yeah, totally. So let me wrap up with maybe one question here, which is, if you had a magic wand and, we talked about like virtual care, we talked about, Hep C population health, we covered a lot of ground. If you had a magic wand to make outpatient ambulatory care better, what would it be?
I think it boils down to capacity building. Yeah, really, because you need to build professional development of your staff to be able to execute. Otherwise, you will have a lot of good ideas, but if they cannot be executed, then you don't become successful. So there are really 2 models, which I will briefly explain. So the first model, we call it the strategic triangle. So where really, it's just like a triangle where the other angle is legitimacy and support. Where do you get support to do whatever you're doing to improve ambulatory operations? And how do you operate within the legal framework of providing good quality care, like, all the HIPAA, all those things?
Yeah.
Then the other angle is operational capacity. That's why I was saying capacity building of staff to really be effective in what they do. Like for your managers to own the business, to understand, like I saw 200 patients, did all the bills drop? And what was my no-show? All those things. So developing those capacities to really run good healthcare systems. Then the other angle of this strategic triangle is the value creation. To say, are you creating value as you provide all these services? So that translates into patient experience, because when you create good value and patients perceive your system as, providing good quality care, good value as perceived or defined by them, then they are most likely to keep on coming. They are most likely to rate you in a very positive way, etc.
Press game, joint commission, all this sort of stuff.
Yeah. So then the second model really obviously has to do with the staff themselves. How motivated are your staff? Are they just doing it for the sake of doing it? Because if someone is not invested in what they are doing, they won't really put a lot of effort in what they are doing. Then also, obviously, it goes back again to capability. People get motivated if they feel they have the capability to do what they are asked to do. So how are you training your staff, and how are you really providing opportunities for professional development, things like that?
Yeah.
But then what is critically important also is the license. Are they empowered to be innovative, to be creative? Because that goes hand in hand with you creating psychological safety within the workplace. If staff feel empowered, feel they have the license to experiment, to be innovative, to be creative, then you find that they are much more engaged. They are much more motivated to provide good.
Yeah, it's less of a job then, it's more for career.
Yes, definitely.
Yeah, I love those thoughts, right? And then I think you really did a phenomenal job using that triangle model to really talk through, all the places where, more efficient, better quality care for patients can be delivered, in the ambulatory context. I think your expertise in this topic is is incredible, and really appreciate you taking the time today to come join us on Digital Health on Air to share how, you can connect patients to ambulatory care in a better way. So very much appreciate your time, and thank you so much for spending a couple minutes with me today.
Thank you so much for inviting me.
It's a real pleasure. All right. Cheers.
Okay. Cheers. Bye.